I welcome you all on the behalf of Family Education Center. To begin with this, I would like to request Professor Aslam, who is in charge of gynae department in Lahore General Hospital.
prenatal care. So we can call it an antenatal care, prenatal, one and the same thing. And we will also be, so this is a part of providing prenatal care. You have to detect the common symptoms of the pregnancy which are uncomfortable conditions, and you treat them. So these are both the topics are interrelated. I'm sure you know about the prenatal care. This is the routine care that should provide when a patient is pregnant. So this is this may include say objective care. It may be detect some medical problems, physical problem, neurological problem. So this is not only about obstetrics. Actually, you have to have a survey of the general health of the patient, and you are ensuring that the patient is he and her infant and fetus that remains healthy for the pregnancy. So what are the objectives? Why do you call a patient because during pregnancy? What objective you want to achieve? If you have to provide prenatal care to a patient, what will you think? What will you be doing? Why the patient should come to you? Anybody can tell me?
In care of the two lives.
You want to?
Two lives. Care of two lives.
You want to care the mother and the fetus. Yes. Right. Anything else? You will be aiming at any other specific objective from the prenatal encounter? You're very right. You want to make sure that the pregnancy is safe for the mother and for the baby. Right. But pregnancy is not the end point. End point is the delivery, labor and delivery. You want to ensure that finally the pregnant patient will be delivering a normal healthy baby. So you do not have to look into pregnancy only, you have to look forward pregnancy, and you have to make sure that the delivery of the baby also be safe. But more than that, the idea, the objective in prenatal care is that you want to make sure that the resources are allocated, adequately. That is probably the main purpose of the prenatal care, that you are ensuring the optimal, a patient who is essentially normal in pregnancy should not have, you should not utilize the resources which you want to reserve for the patient who are high-risk patients who may need a high-tech care. Okay. So what you are doing is you are actually screening the patient for the risk factor, and you are making sure you are categorizing your patient actually during the course of the prenatal. You are ensuring you have to reassess whether sometimes there are additional risks which arise during the course of the pregnancy. Patient is not high risk to start with pregnancy. As the pregnancy continues, she might develop some medical or some medical problem which will place her in high risk. Okay? So this is very important to understand because this is why I am emphasizing because we have a lack of resources in this country, and unfortunately, it's not only the lack of resources which is hurting this nation, it is the poor allocation of resources. There are certain influential rich persons who want to do everything, and they don't want to need anything from other people. You should know that if a patient is normal, even if you are a big boss or very healthy, very wealthy person, it doesn't deserve, you don't deserve to go to a high-tech institution and claim that every time, your baby should be screened, that you should have a fetal monitoring and all these high-tech. These should be reserved by a patient who is really in need of those screening tests and all that, right? So, who should provide the care when you come to the prenatal care? Who should provide? There are many models throughout the world, and majority of the developing and even underdeveloped countries, they have adopted a scheme where majority of the normal pregnant patient, they will go to their midwives and this is again what I was saying a little earlier. See, the allocation of the resources. Every patient walking in our hospital, they demand that they should be seen by the very high level. If you go outside, most of the pregnant patients throughout their pregnancy, labor and delivery will not see an obstetrician. What you call an obstetrician? Not see a medical MBBS doctor throughout their pregnancy. They will be completely under care of the midwife. Now there are many studies which are available. These people, when they devise guidelines, they are all evidence-based. If they are not wasting their resources on the pregnant patient, so they have conclusively, there are certain studies which have conclusively shown that if in a normal pregnant woman, if there is an additional added, if you add a well-trained obstetrician, it will not cause any difference in the perinatal outcome. Normal patient will be much better off with a general physician, and it's a team of midwives and general physician. And they have a more close rapport, they are more comfortable with those people. Sometimes when you go to the hospital the first time, the environment may be slightly different. It's a high-tech computer, and you will not feel very comfortable. But when you visit to a general physician, where you will go to the clinic, you are much more comfortable. You have developed your rapport with those people. So this is a model which is working for the rest of the world, and this is the model which should actually, because this is ensuring that the wastage of the resources will not happen. And only a selective population of the patient will go to the hospital, which will need screening by the obstetrician and care by the obstetrician. But saying that, then the responsibility will be on the general physician, that they have to have a very accurate sense of, they have to screen their population, and they have to make sure that no patient, high-risk patient is missed. They have to categorize low-risk, high-risk, and they have to refer the patient at appropriate time to the hospital. So then in the hospital we have antenatal clinics, and there is obstetrical doctor care where the obstetricians are involved. So there has to be some reason for that. If you have got involved in obstetricians, maybe there is some medical problem, some obstetrical complication arises, there is something wrong with the previous history of obstetric, there is some obstetric complication in the previous pregnancy. At this time, there is some obstetric complication, and then sometimes, there is a pregnancy who is not doing the patient, it is not doing well, pregnancy is not going fine, progressing normally. So these are the sort of patients which you place them at high risk and you take this. These are the patients which have to be screened by the trained obstetrician, and they have to have the high-tech test, and they will need a hospital care. So this is how you should provide the obstetric care. The frequency of the visit is not on the, like on the whim of the patient. Whenever she wants, she can just walk in to the hospital or to the dental clinic. You have to have a scheme, and that should be determined at the very first visit. That this is the scheme. You will have to come according to the scheme. And this WHO recommendation, nulliparous, there is no biggest delivery. You have to call them, give them at least an appointment. But in multi-health, you can reduce them, and you should have. So there is no need for your patient to walk into your office every week with minor complaints. So this is going to be there. When you determine the time of the visit, actually, you have you should have a clear agenda in mind. Why your patient, if you ask your patient to come early in pregnancy, we tell our patient that first visit should be as early as possible in pregnancy. So there should be some reason why we are calling them, what we want to do, why the patient should present early in pregnancy. Similarly, if you call them and say 18 week or 20 week, what do you want to do at that time? Afterward, why the patient should come at 24 weeks? Why she should come at 28 weeks? So for each visit, there are specific questions that at this visit we need to answer these questions, right? So when we start, it should be very early, before, rather preferably before 12 weeks of pregnancy. The first treatment visit should be as early as possible. And when the patient comes, you have to confirm the date. Sometimes we confirm the date based on the last menstrual period. Sometimes the patient has forgotten. So if patient does not remember, this is the best time to take a dating scan. That you will refer on. If you take a scan before 12 weeks, very accurate. You can be wrong by 5 to 7 days. This right on that side. Okay. But a similar patient, when you scan them, you say after 34 weeks, and you were trying to calculate the gestational age, there can be another 3 weeks, 3 to 4 weeks. It's as good as clinical estimation actually. You can just calculate the component, say look like 36 weeks, and then you take ultrasound and you say, okay, you mean the margin of error. So if there is any problem, you have to confirm the date. The patient has to present early. That is the one objective. Then you are screening them, at the start of the pregnancy, and you're making sure that the patient is low risk patient and she's a high risk patient. If you detect any risk factor, then she will not be with you for the rest of the pregnancy. You have to refer her to the appropriate level of care. Then in this, after you have examined, you will plan a pattern of care, how frequently you want the patient will need a hospitalization, referral to the hospital, or she should be with other care with a physician only, and all these sort of questions they should be. And then the information, if the patient has any questions, have most of the information which is required by the patient, that is provided on the first visit, and that can be in the, you can tell them one-to-one, but the best thing is to provide them with some literature written, something written like booklets or CD or something, which the patient can later on refer again and again, and she can learn from that. So what you do? You start with the interview, you ask the LNP, you ask them there is a history of previous pregnancy. No, if there was anything wrong in the previous pregnancy, most of the time the obstetrical performance is repeated by the patient. So that is a risk factor. Similarly, the medical problems, there are certain medical problems like anemia, diabetes, hypertension, thyroid problems. So all these problems, they put the patient at high risk. And there is family history of certain diseases like congenital malformation, preeclampsia, twin pregnancy. All these patients, they are at high risk. Psychiatric illness. Psychiatric problem, they again, unfortunately, tend to recur. Okay, so if there is a history of postnatal depression in last confinement, most probably your patient will again go into postnatal depression in current pregnancy. So all these interview will, by taking an interview, you are actually deciding what sort of investigation this patient will require and what sort of care this patient will need. This is a sort of screening process. Then there is a combination. You start with the weight and the blood pressure, BMI, high BMI, more than any patient of this type. They are at high risk. They should not be treated by the physician. They are associated with a lot of perinatal and morbidity and mortality as well. So they should be managed. Now, a lot of screening will be done on the first visit, and you will start with the blood group, RH status, but you also have to screen for the proteinuria, anemia, sickle cell anemia, and thalassemia, hemoglobinopathy, also come here if there is any history. Then red cell, this RH antibody is very well known to the, but most of the time people do not appreciate. Sometimes there can be the antibody, antibody, ABO, it can also cause, this immunization. So that should have been done. Hepatitis B and C, we are having like a sort of epidemic in this country. So we have started doing this routine scan of the hepatitis, and this is an opportunity window actually. Every patient, pregnant patient, also need to have a pregnancy product. Our results show that we have at least a 5% detection rate of the hepatitis. So that is quite good. And then you also have to screen whether most of these girls they already have contacted Rubella in the childhood, they are immune. But if you detect somebody who is non-immune, you do not immunize them in pregnancy, but after pregnancy you will advise them to take the shot. Ultrasound is not an integral part of antibiotics. You will only perform if there is any concern about the dates. Otherwise, the early scan is not involved. So what advice and information you will give about the iron supplementation, folic acid? Folic acid, if you want to give it, it should only be the first 9 to 12 weeks when the organs are being formed. At that time, when your patient needs folic acid. Vitamin D, as in our part of the country, especially in Indian subcontinent, we have a lot of sun exposure. There is actually no need for vitamin D as injection, method, or fortified food. But there are certain societies where the women are not supported. Those are type of societies where we will find such families exist in our country as well as in India and other subcontinent. And God forbid if we see the regime of the Taliban, then we will give absolutely vitamin D. Food choice is very important, very important, because most of the time it's not the diet, the deficiency of the diet. Actually, we are concerned more about the overfeeding. Most of the time, when the patient is pregnant, they start eating and they say, you are now eating for two. You don't have to eat for two. You just whatever of your previous appetite is almost most of the women, they will not have much more appetite in pregnancy. So they don't have to eat carbohydrate, protein, and fat. So because that is there. So sometimes you have to provide them a sort of written manual that these are the sort of diets which you should, for example, when you tell them they good diet, good diet for them being chicken and with a lot of oil. That is a good diet in the mind of Pakistan. So you have to tell them, the leafy vegetables. If he is taking adequate, they will provide them bulk. That will take care of the constipation, which is a very important symptom in pregnancy. And similarly, it is a rich source of iron, and you may not have to give them iron in tablet form. So education regarding food. The lifestyle changes, exercise especially, and you have to tell them to stop taking any drug if they are on some sort of drugs. Minor disorder pregnancy that we will discuss later on, and breastfeeding, you have to prepare the patient. The patient has to be told during the course of the antenatal, and he has to be prepared about the breastfeeding during pregnancy, not after the pregnancy. And we also have to discuss about the vaccination and immunization. We routine, we only give them tetanus shots, right? But at times there are when patients are traveling or something like they might need some extra shots. This depends upon the requirement of their country where they are. Sometimes they have to like booster shot and bring booster shot and all that. So this is then the parent application. This can, like I said, this can more adequately be done in the shape of a booklet instead of telling them everything. Or sometimes we have in our antenatal we have special video picture videos which you can, when they are waiting, you can watch them, and you can put those videos in the form of CD. Okay, they can watch it. A lot of information you can give in a multi-video instead of a verbal advice. That is okay. That was about the first pregnancy. Then every patient it should be born around 16 weeks. So you have given them a list of screening tests, and they have to come back. Again, like going back to the resources. If I am sitting in an antenatal and I tell them to get a screen, like 4 or 5 tests, so I will get a call every day, starting from that evening. That evening, she will receive a CBC, and she will tell me on telephone what is the result of the CBC. Then, the other alert go on coming, and she will go on telling me. This is the basic resources. You are, because these are the screens that there is no need to walk into the office on the very next day. When you come after 2 weeks, you can bring them 2 weeks, 3 weeks. It will not make any difference. Okay? So what you do, you review the test results, and then you will identify the women where there is some problem with the test, that these are the women who need additional tests, additional investigation, and then you redefine your patient, whether she is still, after screening all those tests, whether she is still a high-risk patient, a low-risk patient, or she has gone to the high-risk patient and she needs referral. So this is what you do on 16 weeks, and obviously you will perform the blood, BP Proteinuria, you investigate hemoglobin, iron. This is the time, and this is a mistake to start the iron at the very the sign of the pregnancy. In the first trimester, no patient should be on immunotherapy, because in the first trimester, most of these women they have nausea and vomiting. So if you put them on iron, it will enhance their nausea and vomiting. Okay. So you have to wait at least up to 14 weeks, and then you can start them with iron if you want. Okay. Then all the patients should come between 16 and between 18 and 20 weeks. And that visit is very important because this is the time when we recommend that all the patients should have a scan, an anatomy scan or an anatomy scan. This is this is the time where the fetus is well formed, all the organs they are completely visible on ultrasound, and most of the major internal and external malformation, they will be visible on ultrasound. Okay, so this screening will tell you that the baby is anatomically normal. If the baby is anatomically not normal, then you have to offer the patient an abortion, termination of pregnancy. So if you do that after 20 weeks, that will be, that will not be a termination of an abortion. That will be a termination. That will be equivalent to inducing labor. And by law, that baby who deliver after that, that will not be an aborted fetus. That will be a preterm baby. When you label a baby a preterm baby, then it will be your responsibility to care that baby. You have to send that baby to the nursery, and you have to have all the effort to save the life of the baby. So you have to have a window period between 16 and 20 weeks when the fetus is large enough and the chance of missing a major malformation on ultrasound is very, very low. Okay? But at the same time, the baby is still at a stage where you can perform abortion. Right? After that, you call them only for nothing respiration, not all of them. You call them around 25 weeks. And this is the time when you start measuring the fundal height, whether the baby is growing properly or not. And you also measure BP and Proteinuria and provide information. Right? And then you call them at 28 weeks. This is a time where a second screening for the anemia should take place. And if the hemoglobin is less than 10.5, then it should be investigated. And the cause of anemia should be. This is important because sometimes patients start their pregnancy with a normal HB, but then the dilution of the blood, and then the maximum in the second trimester, at the end of the second trimester. So many of these patients, they tend to become anemic. They are not anemic to start with, but they tend to become anemic in the middle of their pregnancy. So that is the time, once you have screened them initially, it doesn't mean that they will not become anemic later on. So a scan for the anemia in the middle of the pregnancy is required. And we do that at 28 because the patient still have 12 weeks left. So if you detect anemia, you can very adequately treat them on oral iron. There will be no need for blood transfusion, IV, or intramuscular, just oral medication. And by the time she is about to deliver, her hemoglobin will be back. If that is by this time secure. Then there are patients who are anti-D negative and they are non-immunized. So in pregnancy you have to give them a dose of anti-D, prophylactic dose of anti-D, and you give them at around 28. You can give 2 doses. This is also the time when you test them for gestational diabetes. Hypertension, gestational diabetes, these are 2 diseases which are very, very common in pregnancy. But you will not see them in the initial, if they are because of pregnancy. If the patient is already hypertension or diabetic, then she will be diabetic and hypertension when she gets pregnant. But if he has to develop hypertension or gestational diabetes because of pregnancy, then this will be in the middle of the pregnancy, not early onset. Okay? This is how we differentiate. So best time to pick up that will be in the middle at around 28, anything between 24, 28 to 30. And the gestation diabetes, you again have to choose what test you want to give them. If you just offer them a random test, you will miss a lot of patients. Okay? If you ask them to go on oral GPT, it will be again wastage of resources. Okay? You will have to, the pickup rate of gestation diabetes is in the range of 3 or 4%. So you will have to, have 96 unnecessary oral GPT to pick up 4 patients. So there is a test which is known as 1 hour test. You ask them to come to the clinic as there's no need to be fasting. They can come and then we give them 50 gram load of iron, glucose, and then exactly after 1 hour, just take one sample. Okay. And if it is less than 120 milligram per deciliter, the patient normal. If it is more than 126, that means it is a normal test, and you will have to ask the patient to take the full oral GP. Okay. So you can save a lot of resources if you perform this 1 hour glucose challenge test. We call it 1 hour glucose challenge test. It's not the whole oral GPT. It's just a reduced form of the glucose problem. Yes, no. This is you will not find that in the the guideline of the RCOG is not in the national, but these are our guidelines. Because the gestation diabetes rate in this part of it is very high, number one. And secondly, we do not our patients, they never go to doctor. So even the normal, not only the gestational diabetes, but even the pre-existing diabetes, that will be, we pick up in pregnancy. The patient is diabetic, she's hypertensive, she has diabetes both, and she wouldn't know. And it will be first time in pregnancy when you come to know that she is also hypertensive. And that, that will be a problem whether this is a pregnancy induced. So if they come very early in pregnancy, they were not diabetic, not hypertensive, and later on we say, okay, this is gestation diabetes, pregnancy induced hypertension, otherwise they may be essential hypertension and pre-existing. So our guidance, according to the Pakistani guidance, we prefer that all our pregnant patients should have 1 hour screening test. Okay, and we will pick up a lot of patients. Okay, then another visit that will not be in the nulliparous, only for the nulliparous women, not the all pregnant women. So purpose of this will be just review the test, and secondly you will check the growth of the fetus, whether you will note one thing in this, that I have been consistently telling you just measure the height. There is absolutely no attempt at finding out the presentation of the baby, because it doesn't matter. What we are concerned is the growth of the baby, whether the baby is going from the not, whether the baby is lying before 36 weeks, whether the baby is lying by pre-presentation, parallel presentation, process presentation, doesn't matter. And what is happening in this country is, the patient will go at 22 weeks for an ultrasound scan, and they will write down, like 4 letters, the baby is in pre-presentation, and that will be part of alarming, for the baby. They start running. 24 weeks, 30 weeks, 28 weeks, baby is reached. Just leave her alone. It's actually, sometimes the baby turns the position 4 times in 24 days, 24 hours. In the morning it is reached, in the evening it crosses, then it's varying, it's again reached. It's all moving. Reason being that this liquor is more in quantity, the baby is still small in size, so it's literally floating, swimming in liquor. And it can go and change any position, but after 36, lighter will reduce, and the baby has to stay in propellant position. So it is only the fundal height, symphysis and fundal height, and then we just keep the one end at the upper end of the symphysis fulvus, and the other end at the height of the fundus. And by a simple formula, you measure it in centimeter, and 1 centimeter is equal to 1 meter. If it is 30 centimeter, the patient has a fundal height. This is a simple formula. You don't have to finger measure. So it's more accurate than the finger measure. Right, then at 34 weeks, we call them back, all the pregnant, before this is the time, we'll give them an RH, second dose of the, but this is also the time when, the growth restriction, IUGR, that become apparent, started becoming apparent. This is the time where most of the women who has to go into preeclampsia, they become preeclamptic, and this is the time, most of the time, where the patient has a low length patient at the time, and the patient will have. So many reasons to call that a 30-minute week. So we are again concerned about the growth of the baby, whether the baby growth is proportionate to the gestational age or not. And then at 36 weeks, you call, this is a very critical time. Now is the time to check the position of the baby, like I said, and if the baby is not compelling, there is a simple procedure. This is known as the external compelling version. From the abdomen, you can just rotate the baby. If it is in transfer position or it is raised presentation, just by rotating the patient, you can bring the head down and the patient will deliver as compelling. There is no need for cesarean, no need for cesarean section. So it's a simple procedure. But you have to protect them at time, at the proper time that this is a malpresentation, and you need to rotate them. Right? This is the reason we call that. There are certain patients where early pregnancy scan will show you that there is sometimes low lying. Now, if it is only low lying, not reaching to the os, covering the os, then there is no cause of concern. Most of these placenta later on you will find has gone up. But if the initial scan has shown you that this is the time, anything after 30, but at 36 weeks actually, specifically, you need to have to rule out the placenta period. So you will need a scan at this time. In those patients, there was a more like placenta in the scan. Not all.
Sir, the ECV can ECV.
External compelling version. You rotate the baby and you bring the head down.
ECV application?
External compelling version. You are doing it through the abdomen, so that is external. You are bringing the head down. So your version is you are changing the place into compelling. This is not.
Are there any complications with ECV?
Yes, of course there are a lot of complications. You can detach the placenta, you can a thought can be created, and you can, sometimes you are very rough. You can actually, there is any scar in the uterus, you can actually rupture the membrane, or you can rupture the uterus and you can But this is, we do ECG without anesthesia. There are people who try to do it under epidural or anesthesia, and then they use some therapeutic agents, and they are not very forceful. If you are not very forceful, then probably there is not a risk. Okay, then at 38 again, this is just you are waiting for the onset of the labor, and you are calling the patient more frequently, and you are checking that nothing is wrong with them. And at 41 weeks, now 41 days when the patient has gone beyond our dates, 40 weeks is the expected date of delivery, and most of the fetuses they deliver around 40 weeks. But 41 weeks is still no cause to worry, but most of the physicians, they will like to discuss the reduction of labor at 41 weeks, because if the cervix is favorable, so you can just leave the membrane, strip off the membrane and sleep. Most of the time the patient will go into labor by sleeping the membrane, or you can just give some symphysis-fundal drip, it can be started, because you do not gain anything extra by prolonging the pregnancy into 42 weeks. But on the other hand, if your patient is not fit for induction, I'm only talking about the patient who is fit for induction, who will go into labor easily. But if the cervix is still not favorable, then it will be a sort of mistake to use them, because your patient may end up in a stage. Ultrasound, this is just repetition, just to emphasize, because there is a tendency that every pregnant patient, she is getting a scan in this country on each and every visit. Obstetrician will perform an ultrasound himself, herself, and then he will refer the patient for additional reassurance, he will refer the patient to ultrasound. For a normal pregnant woman, you may have an initial ultrasound scan at 12 weeks if there is any problem, you want to make sure about the dating, if there is any discrepancy. Sometimes the patient has a concern about pregnancy and she doesn't know whether she is pregnant. But these are very limited patients. In normal pregnancy, the 12-week gestation, you have to screen certain population for certain. There is a history of congenital malformation. The patient is elderly. There is a family step-down syndrome, and you want to screen them. This is known as a first trimester screening to triple test or to perform the ultrasonography or perform the other screen test. So that is the only indication. If your patient is falling in that category, so a screening test at 12 weeks will include an ultrasound. But most of the patients, they need to have just one, a single ultrasound between 18 and 20. That will confirm their dates, because still the dates will be very accurate, and that will rule out all the major abnormalities. And if the scan is normal, then and the patient remains normal throughout their pregnancy, there is no need, no reason to, if you have seen carefully, I have gone all the pregnancy without checking the fetal heart. There is no need for that actually. If your patient has come and she is feeling the fetal movement, and you are feeling the gestational height, fundal height, and you feel your baby kicking your hand, so why on earth you would like to listen to the fetal heart? What will this add? This will add nothing. Okay? So these tests are just superfluous, but still they are done in routine, and the patient will be sometimes they are very irritated. You do not, try to see the presentation, do not check the fetal heart, but actually in normal pregnancy, these are not required. Okay? Okay, quickly I will go on the common problems first trimester, nausea, vomiting, tiredness, frequency of heartburn, constipation, trust changes, and these are the most frequent problems which your patient may complain of in the first trimester. Okay, so nausea and vomiting is the most common. We call it morning sickness, because most of the women, they will have 1 or 2 vomiting in early morning before just after breakfast, and this is nothing serious. But some, about 1 to 2% of the women, they have intractable vomiting. We call it hyperemesis. And the definition will be that it's not only the vomiting. The patient should show the sign of dehydration and electrolyte imbalance. The condition is so severe that the patient will